pain, 10, the worst pain you can possibly have. 3 is mild, 7 is severe, okay, and 3 to 7 is moderate pain. So when does it peak? Peaks about 6 hours, then it goes down. 24 hours, there's a rebound, probably caused by things like swelling, migration of cells, lymphocytes, leukocytes, polymorphonuclear leukocytes, late synthesized mediators, histamine serotonin. Look at this, long duration, 8 hours, toric oxide. We know that dolomite's fairly long, but look at this, acetaminophen 650 with oxycodone 10 milligrams, ibuprofen 400 milligrams with 1,000 milligrams of acetaminophen. Look at the NNT, 1.5. So you can extend the duration of the analgesia by upping the dose of the ibuprofen and the acetaminophen. You might say, .7 to 1.8 mLs for infiltration, you're wimping out. That's the dose unit for infiltration. Okay. Why? Why do you have to use so much? Well, we have to create a reservoir so the drug sits there long enough to be able to diffuse through the bone. It's a reservoir because the circulation is competing with the bone for uptake of the anesthetic. Okay. About this stuff, so I don't like it. And then lidocaine, great for maxillary infiltrations and inferior alveolar nerve blocks, equivalent to articaine. And then here's articaine, the two preps, 1 to 100,000 epinephrine, and the silver is 1 to 200,000. I cannot tell you as of today whether the 1 to 200,000 will give you the same outcomes as all of the studies that I've cited, because it's new, it's relatively new. And why did the research focus on 1 to 100,000? You scientists, because that's what lidocaine had. So they wanted it to be kind of apples to apples, right? So they used the same vasoconstrictor concentration. And here's Marcaine, Vivicaine. This is the long-acting local anesthetic. I think it is advantageous for surgery. If you use Marcaine, it will reduce the amount of analgesics you have to use postoperatively by 1 dose, scientifically proven, which is good, that's fine. 3% carbocaine. Scandiness, 3% mepivacaine plain, great for medically compromised patients in whom epinephrine is contraindicated. Oh, this one I have no use for whatsoever. 2% mepivacaine with levonorepinephrine, neocobephrine. Don't like it. Why? Because we don't know anything about levonorepinephrine. Nobody's ever published or studied the maximum dose of levonorepinephrine. Tenths of a milligram of epinephrine into that finger probably would be bye-bye for the finger because of the intense vasoconstriction that would have occurred, would have strangled the tissue, okay? So you gotta be careful, but auto-injectors are making a resurgence. Unfortunately, this is the absorption of the aspirin or the clopidogrel or the Tagrelor, whatever antiplatelet agent they're using for you. Okay? Oxygen. What would oxygen do? Well, in normoxic individuals who have oxygen saturations greater than 90%, this lowers cardiac output. Okay? Which could be good, except that you're also reducing perfusion of the heart muscle. What about nitroglycerin? Well, there's some evidence that nitroglycerin will not contribute to enhanced survival after myocardial infarction. It does not improve outcomes. We used to think, oh yeah, man, you get nitroglycerin, you're set. You're going to be able to survive any kind of a myocardial infarction. So the one Are there any questions?
خلاص خلصنا أول يوم. طبعا كنت أحاول إني أصور لكم أكتب بنفس الوقت، فلو في spelling mistakes معلش سامحوني. It was a good lecture. It was a good day. أنا أغلب الكورسات اللي بحضرها this type of meetings كده medical emergencies، لأنه هذه اللي لازم نحضرها بالها عشان الرخصة، وهذا اللي يعني ممكن يكون فيها new information. بس ال other courses are at the general dentist level. أو I like to go to the implant courses حتى لو على general dentist level عشان أعرف كيف يعطوها، وأشوف what are the general dentists interested in وكيف ممكن أطور الكورسات اللي أعطيها.